Dr.
Want
Silvers
this?
is the Chief Medical Officer for Aspire Allergy and Sinus and a board-certified allergist specializing in environmental and food allergy diagnosis, treatment, and prevention. He oversees the allergy program and protocols and leads the food allergy and oral immunotherapy program at Aspire. He's considered a leader and expert in the field of food allergy. And my favorite fact is that he was named best of the best allergist in Austin by the Statesman. So just a little, he acted surprised by that.
As it is with OIT at this point, but that's how OIT started, 20 years ago. We'll talk about further feeds, there are a lot of them. And finally, we'll talk about SLIT includes other things. Okay, so just to briefly go through this, because I think most of y'all have a pretty good understanding of the differences, OIT is slow, incremental increases in ingesting the food, starting at microgram amounts of protein, moving all the way up to milligrams or grams of protein. For our protocol, we typically dose them weekly, so these are weekly visits for these patients. It is a lot of work and effort for the family. And as Katie was saying earlier, we can adjust the microgram dose. We can go to 300 milligrams of peanut protein, and I'll tell you why that's a good idea in a second, or we can go up to 6 to 8 grams of protein, where they can eat a 300 dose. SLIT is a little bit different. This is where we're using extract. By commercial extract, it's the same stuff you focusing on the back. We administer this protein under the tongue on a daily basis. Typically, much easier to do lower amounts of the protein. It's a slower process. It takes time. But for some families, this is the way to go. OIT is also dosing therapy. Way back when we started this, we were doing twice-a-day dosing. And with that exercise restriction, you can imagine that is a lot for a family to handle. We quickly found within a year or two of doing this that once-a-day dosing is sufficient. No exercise, we can do 1 to 3 to 4 foods at the same time, which saves time, may increase the risk of anaphylaxis, but saves time and money for that matter. And more data is coming out, as Katie alluded to, that starting young is better. We get better overall rates of sustained unresponsiveness, fewer adverse reactions actually. So I try to start as soon as we can. SLIT though typically requires more frequent dosing. For our protocol, it's twice-a-day dosing. But the benefit is because we're dosing with such a smaller amount of the protein, adverse reactions are much less uncommon. In fact, we only have a 20-minute exercise restriction for SLIT, and that is, in my mind, very conservative. I think most of these kids could take their dose and go run around and play without any problem. Currently, there's no data on multi-food treatment, although we are doing some of that in clinical practice already. And just like with OIT, we can start at a young age. because we are, as we'll see, kids tend to do better with this. Adverse reactions are common. We talked about that. The amount of epinephrine use is 5 to 15%. We typically have to be in constant communication with our patients to adjust doses. They skip a dose, they are sick, they're going on vacation. As most of y'all know, that's a lot of communication that comes through us. It's much, much harder to do from a standpoint of a practice. SLIT is oftentimes kind of just let them do it. It's so much safer that we don't have to adjust doses all that much. If anything, we see maybe a little itch in the mouth with some of these kids. To date, in our practice, no one's needed epinephrine, so it's a lot easier for our staff, for us as the providers, as long as they're taking the dose consistently. So I want to go back to Katie's point about the 300 milligrams of peanut protein. Why is 300 milligrams kind of a target dose for some of these groups, Palforzia, for example? This study is complex, but it has some really interesting points. What they did is they went through various different types of snacks and treats that kids can buy that may have cross-contamination with peanut, okay? So they went through the risk of reacting to these foods based on the level of cross-contamination that may be there, the amount that kids typically eat, and they came up with kind of a risk of reacting based on how sensitive they are. Meaning, if someone has reactions to peanut with only 1 milligram of peanut protein ingestion, they give you a risk. If they have 1,000 milligram peanut protein threshold, they gave you a risk. Obviously, it's going to be much lower for those kids, right? And that was helpful information as it was. But then they went and said, what if we took a kid who could only tolerate 1 milligram of peanut protein and we increased the threshold? What happens to their risk of reacting to these cross-contaminated foods? So if we rose this kid's threshold from 1 milligram of peanut protein to 3 milligrams, we triple it, the risk of reacting drops by 22.7%, okay? What if we rose to 10 milligrams of protein, 46.8%? What if we get out here to 300 milligrams? 99.5, 99.4, 99.1, 98.5. So the risk at this threshold really starts dropping with cross-contamination. And when you talk to a patient who has, or I should say family, who has a food allergic kid, their number one thing they say to me is, I want to be free from the risk of cross-contamination. Some want to be able to eat the food freely, but almost universally, getting to this point of protection is their number one goal. So I'll refer to this 300 milligrams of peanut protein through the talk. This is why. Okay, so we'll start with kind of the first study that came out back in 2011. Edwin Kim, you'll see Kim throughout the talk. He's done a lot of this. They did 18 patients, aged 1 to 11. This is kind of the first study looking at, well, does this work or not? They treated these patients with 2 milligrams of peanut protein daily, sublingually, for 12 months. What they found is the active group tolerated 20 times more peanut protein than the placebo group. Okay, 20 times, that's impressive after a year. The placebo group, at the end of that 12 months, tolerated 85 milligrams of peanut protein, 1.71 grams of peanut protein in the active arm. So we're well beyond that 300 milligram dose. In fact, we're talking about, 2 or 3 peanuts here, maybe 4. No, there was kind of a ramp-up phase, yes. But they were in the maintenance 2 milligram daily dosing for 12 months. The major drawback with this study, they didn't start with food challenges. They just had patients who had convincing histories, convincing tests. But still, that's a huge difference. So they felt they were onto something. So then we'll go on to the COFAR study that was done in 2013. They looked at 40 patients. Now we're looking at older kids into adults here, 12 to 37 years of age. They treated them for 44 weeks, and this was placebo-controlled. And they also had a crossover study that I'll talk about with the next slide. The active arm in this study, we were treated for 68 weeks at 1.386 milligrams of peanut protein. A little bit less than the other study, but at the end of 44 weeks and then 68 weeks, you'll see that the amount of peanut protein they successfully consumed rose to almost a gram. We're still seeing pretty significant amounts of desensitization here. So they did this extension study where the initial 20 patients that were in the active arm stayed on this 1.386 milligrams of peanut protein, but then they crossed over the placebo arm from the first study. They increased it to 3.696 milligrams of peanut protein daily, okay? Compared them to after another 2 years. Those that stayed on the low-dose therapy really didn't change. They stayed at 99.6 milligrams of protection. But those that increased to 4 milligrams daily, they went up to 5.5 peanuts of protection. That's a lot. In fact, 2 of the 17 patients passed a full challenge of 10 grams of peanut powder. And then all 4 of the patients that passed the challenge initially, they remained desensitized after 8 weeks. So some degree of sustained unresponsiveness there. Is 8 weeks enough to say these patients are cured of their allergy? Of course not, but at least it's reassuring data. Excuse me. Okay, so moving on to where it gets really interesting here. Dr. Kim, again, went back to the young population, 1 to 11 years of age. These kids did peanut slit for 3 to 5 years, dosing at 2 milligrams of peanut protein daily. Okay, again, there was kind of an escalation phase at first, but at the end of that 5-year period, 37 of 48 subjects, that's how many completed. 77 completed the trial, 32 of 48, or 86.5 per protocol, were able to consume 750 milligrams of peanut protein. That's 2 to 3 peanuts. That's pretty good numbers, okay? 62.2% per protocol were able to consume 9 to 11 peanuts. A third passed a full challenge. So what they did is those 12 patients that passed that full challenge, told them to stop dosing with their slit for 2 to 4 weeks, come back in for a challenge. 10 of 12 passed that challenge. Okay, this data is better than what they're going to come out with the peanut patch. This is really impressive data. But he wasn't done. So Dr. Kim presented this in 2021. He treated 50 kids, aged 12 to 48 months. So he went even younger, 1 to 4 years of age. And he bumped the dose up to 4 milligrams of peanut protein daily. What they found is the median successfully consumed dose that initially was 143 milligrams increased to 4,443 milligrams. High levels of protection after 3 years of therapy. 14 of 19 passed a full challenge. And then after stopping therapy for 3 months, 12 of those 14 still passed the full challenge. Now we're looking at 3 months of sustained unresponsiveness here. Pretty good. Younger, higher doses. Okay, so we've written some pretty good data here. I mean, that was 50 patients in the study, right? Not enough to really change the world, but it's really impressive data, I think. But we have a lot of questions we need to answer still. How much protein is necessary? How much do we need to dose? We saw that 4 milligrams did better than 2, 6 milligrams do better than 4. Those studies haven't been done. What's the level where slit is still effective and we're not giving too much protein, increasing adverse events? Is 300 milligrams enough for all patients? I think in many cases, yes, that's going to give them significant quality of life improvement, but maybe we should be looking at 1,000 milligrams of protection. That's kind of a question you have with the family, what their goals are, and it really dictates where you go with OIT versus slit versus other therapies that may be coming down the road. Excuse me. So the other question is, what can and can't patients do following SLIT? There's a lack of quality, I think, from the FDA when it comes to labeling foods for food allergies. Most of those labels don't mean a whole lot, honestly. May contain, processed at a facility. There's nothing out there that really gives you a true sense of how much protein may be in these packages. So I think changes need to be made at the FDA to make that more meaningful, essentially. Geez, I'm running out of time here. I'm going to skip ahead. Sustained unresponsiveness versus tolerance. This is a question I deal with all the time, and I do less and less sustained unresponsiveness challenges because I don't know what I'm doing, frankly. So if someone can go off therapy for 3 months and pass a challenge, awesome. What if we do at 9 months, 36 months? How long is this going to last? Is this like SCIT, where you can do well for years to decades, and then your symptoms return? We don't know this. So for me, I like to keep dosing on a fairly regular basis. Who would benefit from SLIT the most? A lot of times for us, it's families who are super, super anxious or who have had really significant bad life-threatening reactions. This is completely anecdotal, but I had a young lady who came to see me. Her first exposure to cashew, she wound up intubated in the ICU for 5 days. Put her on SLIT, and after 2.5 years of therapy, she came back and ate a cashew in front of us. No symptoms. That is life-changing for that family, right? So it's those patients who I think I almost always want to start in with SLIT and then potentially graduate into OIT, or maybe just keep them there. Maybe that's what we do with them. Who are the responders? Can we predict before we start who is going to be in that 85% that has 2 to 3 peanuts worth of protection when they're young? We don't know yet. There's a lot of data we need to gather with regards to all of this. I'm going to skip ahead a little bit here. Beyond peanuts, peanuts just the tip of the iceberg. Everyone who comes in is interested in peanut, but they also want to treat their tree nut allergy, their sesame allergy. They want to be free from everything. Peanut's not enough. This is a hazelnut study that was done, and they did find that most of the patients increased from 22.29 grams to 11.56 grams of hazelnut. It works on tree nuts, essentially. Next, we have milk. There was a 40-fold increase in the amount of milk that was tolerated, but quickly they went back to being sensitized within weeks of stopping therapy for milk. Okay, so I know you'll have a lot of questions. I skipped over a lot there at the end, but all these slides will be available to you, and I can email you anything you've got. Okay.
All right, so we're going to open it up for some questions. I know Dr. Weibel had one.
So I love doing food challenges, and it gives us a lot of information about thresholds, how consistent it is. But in your experience, where have you adjusted starting OIT at maybe a higher dose versus the 0.5 milligram to 6 milligram, that long day one, because maybe their initial threshold was much higher?
He fails. I think they turned me back on.
Oh, okay.
If someone fails at like dose 5 or 6 at the food challenge, which is 1,000 milligrams, 4,000 milligrams of protein, even at the 300 milligram protein dose, that's dose 4, then certainly we can skip some of the OIT and just go ahead and start them daily dosing at a higher amount. I don't think clearly you're not going to dose them at the dose that they failed at. You probably go back a dose. And then start them there with daily dosing. So you're right, if you do a food challenge and we find that their threshold is pretty high, then they could skip a good portion of the beginning of OIT and start dosing at higher amounts.
I do that fairly regularly. A lot of it depends on how they fail. Is it a spectacular failure, or is it a few hives? Where they fail, is it the last dose or is it the second or third dose? But a lot of times we'll use that information to kind of start them dosing the day after the challenge at a lower dose. Yeah, so I've found that oftentimes so she asked if y'all didn't hear, if you do a sustained unresponsiveness challenge, they've stopped dosing for 4, 6, 8 weeks, they come in for a challenge and they fail. I'll kind of do what we were just talking about. It depends on where they fell and where the symptoms, what type of symptoms they were. So if they fell on the 4th dose, I'll send them home on the 3rd dose, and we'll kind of work up from there. It's usually not too hard to get them back to where they were at that point.
It's been my experience that they usually fail on higher doses. So, I mean, almost always they fail like close to what their maintenance dose was before. So it's not really hard to build them back up.
Dr. Silvers, presumption is that you're giving from an extract 2 milligrams of peanut protein to start with, or at your maintenance. How do you know that there's actually 2 milligrams of peanut protein?
Good question. So the manufacturer we buy from has not been overly welcoming with the questions I have about that. But fortunately, there are studies out there that if you do a little calculation and a little math, you can figure out how much protein there is in the extract. So there was an article that came out looking at various amounts of peanut protein in various peanut butters, different snacks, just to kind of give everyone an idea of what we're dealing with. But they also looked at the 2 major manufacturers, ALK and Greer, and they didn't tell you which one was which, but if you do a little digging, you could figure out which one was which. So I have a pretty good idea of how much we're dosing with.
With the data so strong, do you see any role at all for a monoclonal antibody in association with food allergy treatment?
That's a good question. I think there's a lot of unknowns still with SLIT, and I think buy-in for SLIT is difficult because families are dosing with this extract that doesn't look like peanut, it doesn't smell like peanut, and they don't know really how much they can tolerate until we do the food challenge. So the number of patients who opt to go through food SLIT is much lower than with OIT, and I think that has something to do with it. The other thing is this is looking at young kids, and getting those kids in early to start therapy is a struggle as well. I think if we could, I think we could change the course of a lot of kids' lives, but oftentimes we're seeing them when they're 8, 12, when the data kind of starts dropping off a bit. But I think if we could do these things early, yeah, it would be huge, and we may not have to go that way.
I think there's a better case of omalizumab with OIT. I think there's a better case of using omalizumab with OIT than there is with SLIT, right? Because we're trying to avoid epinephrine-treated reactions, and I always knock on wood when I say this, but we haven't had anybody need epinephrine with SLIT in our practice. But of course, it happens a lot with OIT.
So the way I understood it was that you use, for SLIT, you use a regular Greer extract. How many cc's is that for 2 milligrams?
Not much. It's about 300 microliters.
So
Like
that's
3 to 600 microliters.
how many drops is that? Or is it
3 to 6 a day.
3 to 6 drops is 2
Mhm.
milligrams? And you maintain that for a period of time?
So just to be clear, it's a larger vial and a larger pump than our typical SLIT. Okay, we're able to find larger ones, so you're administering more each pump.
And then, can you clarify when you do your first challenge? Or do you just do a regular oral, progressive oral food challenge after they've been on SLIT for a period of time? How does that work?
So we kind of do one or two things. Either we do a challenge after they've been on therapy 12, 18, 24 months, or what happens a lot, these families will move into OIT after that. So we don't even do a challenge. they elect to do this because of one of the slides I skipped over here. Very small study, but it looked at doing SLIT before OIT, and they found a lower adverse event rate. Pretty significant drop in the adverse event rate, actually. So a lot of families will use SLIT as kind of a gateway from the outset to move into OIT.
A rather complicated case. You have a 12-month-old child that can tolerate baked egg, but partially cooked egg 2 hours after ingestion causes severe nausea, vomiting, diarrhea, something that doesn't sound like IgE mediated. It sounds like FPIES.
Yep.
What do you do with that child? I mean, I'm afraid to challenge the child in the office because it takes 2 hours, and then you've got, you have a kid maybe going into shock. We don't have the ability to draw CBCs, look at white blood cell counts and all that kind of stuff. So what I've told the mom is we're just going to keep them on baked eggs and wait and see what happens.
That's probably what I would do, particularly if skin prick or serum-specific IgE levels are low or negative, and you've got a pretty good idea that, yes, this is FIs, then, yeah, I would keep baked egg going, and I wouldn't do anything else.
The rest are high, so it looks like we're dealing with two different things in the same baby.
All right, then that's even more confusing, yes.
All right, Dr. Makel.
Many of these kids that I see are now 16, 17, 18 because 8 or 10 years ago we didn't have that many things available. How much a disadvantage if you start a mid-teenager compared to a 5 or 6 year old? What statistically, how much do we lose?
Statistically, I believe you did a study with Wasserman where it was a 17% odds ratio decrease per year of age. So it decreases pretty significantly as people get older. No, that's of achieving maintenance.
It's harder with the teenagers for sure. They have to be very motivated. That being said, we've got 3 or 4 adults, I think, now going through OIT. So I don't let that dissuade me from starting, but I think you also have to be very upfront with them and saying, hey, this is the data that you see out there is not going to be necessarily applicable to you because you're 23.
It's definitely worth a try. It just may be a kind of harder, slower road for them, for sure. My own son started when he was 10, almost 11, and he's done great. So, I mean, anecdotally, older kids can do really well.
Dr. Silvers, the European literature for pollen sublingual immunotherapy recommends that the patient hold the drops underneath the tongue for 2 minutes. How do you do that in a young kid?
Good question. You try your best. That's what we tell our patients as well, knowing that they probably won't. But even the day, I mean, Dr. Kim's not any better at getting a kid to hold the slit under his tongue than I am. So the data's still out there that it still will help. It's practice, but knowing full well it's not perfect.
I do tell my patients, you can't swallow with your mouth open. So if they can play a little game with their kid about keeping their mouth open, just like, for a little while, that'll at least give them a few seconds. Get into the 2 minutes with a toddler is just, not really obtainable, but they try their best.
Other questions? So, we hear a lot in our patient population. We saw a video the other day just talking about how a lot of allergists don't treat food allergies. They'll test them, but they don't treat them. So, number one, what do you say to patients when they come in? Because usually they've been to multiple other allergists. And then what led you guys to treat food allergies yourself? I think I know about Katie, but Dr. Silvers.
So I'm in a little bit of a unique situation, I should say. My perspective is probably different because I've kind of made a little bit of a name for myself. So patients are usually seeking me out wanting therapy. So, but for my new patients who have just diagnosed with food allergy, I don't even talk about therapy for probably 2 to 3 visits. You are throwing a lot of information on them at the outset. You're changing their life. So you don't need to fill it with all this other stuff yet. Get some time to know the family, know the patient, Then you start kind of bringing it on. Hey, these are options. These are big options. These are big things we're talking about here. But I think in most families, they are at least interested in it. And I would say even our patients who aren't successful, most are glad they tried. There's very few that come back if they've not done well with OIT and say, what in the world have you done to me? They're usually like, I gave it a shot, it just wasn't for me.
We've talked about that we see better results in younger patients. What is the youngest patient that you've started on either SLIT or OIT? And that's for both of you guys.
I keep all the data, so I think the youngest we started practice-wide is probably 9 months for OIT. Little bitties can do it. The parents are very leery about it, though. They're worried because the child can't express themselves, but I tell parents, you know when something's not right with your baby. And there's some pretty good data that reactions are lessened, just in general, food allergy reactions are lessened in infants. So why not start when the reaction is not going to be quite as bad? You have anything?
I think 9 months. I think for SLIT, 2, I think, is the youngest. Have we done younger than that?
I don't know.
We'll have to double check that.
Yeah.
But yeah, it's usually easier for the young kids in multiple reasons, not the least of which is they don't have the fear and anxiety yet, and they
also
don't have the
hate the
taste, the
taste.
version that's developed with that. So you can get them to eat things that otherwise they may not want to.
I guess one last question. Have you been able to publish any of your observations, protocols in peer-reviewed publications? The Oceanside Publications has a journal of food allergy that may be of interest to you if you desire.
That's a goal of ours for sure. We track all of this very, very closely. I shouldn't say we. Katie tracks all of this very, very closely. So we have a lot of good information, and we've done some pretty crazy things with SLIT. I mean, we've done mustard, we've done seafood, and had pretty good results. So we have a lot of good information that we need to get out there for sure. And just last thing that hasn't come up, and it kind of surprises me, is cost.
I was going to ask you.
Yeah, I mean,
It's
SLIT's
expensive for SLIT.
awesome, but it's expensive.
Yeah.
Extracts are very
I mean,
expensive.
4 milligrams, that's thousands of dollars probably.
A year.
Yeah.
Yeah.
Easily.
So this isn't something that we can do for everybody. We have toyed with the idea of using actual food as opposed to extracts. There are some articles out there suggesting you can do that. That might make it more approachable for more families, but it's expensive.
Dr. Harvey.
That's not a question for me. That's a question for our colleagues in the back there. Rumors are that there will be an
There's a
indication.
rumor.
The rumors are there will be an indication that comes for food allergy in the near future, and I anxiously await it for our OIT patients.
That's a great reason to go visit our exhibitors after this, during our break. So I am so sorry we are out of time. I know this is a super interesting and just amazing work that they are doing. So